In this video, we present a brief overview of our paper on the health benefits and cost-effectiveness of cytosponge screening for Barrett's esophagus. This work was motivated by the fact that esophageal adenocarcinoma has an increasing incidence and poor prognosis, and Barrett's esophagus is a known risk factor. If this condition could be detected and treated early, it could help in the prevention of a percentage of cases of adenocarcinoma. In this sense, a population-based screening could be very beneficial. Currently, Barrett is diagnosed by endoscopy followed by biopsy. Although this test has high accuracy, it also has the disadvantages of being an invasive and expensive procedure, which requires medical expertise and specialist facilities. On the alternative side, there is a new nonendoscopic device called Cytosponge, which you see in this picture. This seems an appealing alternative since it's low cost, minimally invasive, and could be available in primary care or clinic. So we designed a model to compare cytosponge screening against two other methods, either no offer of screening or screening by endoscopy, which is the current practice. The comparison will be made in terms of health impact or the percentage of adenocarcinoma cases that could be prevented, and the cost effectiveness. We developed a decision analysis model that combines a decision tree and a Semi-Markov model. A Semi-Markov model was necessary due to surveillance. The diagram is a simplified version representing the states of our model. The patient is invited to screen, and according to the accuracy of the test and prevalence of the disease, it's classified in one of the health status in the gray area. If the patient has non-dysplastic Barrett's or low-grade dysplasia, he'll go under surveillance. If the patient has high-grade dysplasia or intramucosal cancer, then he'll be treated by either endotherapy or esophagectomy. Also, in any scenario, if the patient becomes symptomatic, then he'll be treated. After treatment, the patient moves to the post-treatment state until death. Also, death can occur from any state of the model, according to population mortality statistics or mortality associated with the treatments. We use microsimulation to simulate life events history for 50-year-old men with GERD symptoms. The main outcomes of our model, presented in this table, are the number of symptomatic cases observed in a cohort of 100,000 people, the mean cost, and the mean quality per patient. The last two are used to calculate the incremental cost-effectiveness ratio, also called ICER. Under our assumptions of uptake of either screening intervention, which you should check our main paper, Cytosponge will reduce the number of cancer cases by 19% and endoscopy by 17%. Both endoscopy and cytosponge screening have similar health gain. Look at the mean qualities here. So the comparison is mainly in terms of costs, and cytosponge is associated with lower cost than endoscopy. We also performed a sensitivity analysis to account for the uncertainty on the outputs, such as transition rates, costs, utilities, prevalence of Barrett's, etc. The details of the sensitivity analysis are in the main paper. So, in summary, this paper is based on up-to-date evidence for model inputs from recently published literature and consensus statements. We examined the contemporary management of patients with high-grade dysplasia with endotherapy followed by surveillance. The use of microsimulation to evaluate the cost-effectiveness of Barrett's screening adds substantially to previous methodologies by allowing patient history to be modeled directly. The main message here is that cytosponge screening can be a useful test to detect Barrett's, capable of reducing mortality associated with esophageal adenocarcinoma at an acceptable cost. The main findings show that it can have a wide range of benefits to both patients and the health system. Thank you.